Welcome to Myeloma 2015. We've just completed the second day of the meeting here in Boston, and I'm joined today by my colleagues, Professor Leif Bergsagel from the Mayo Clinic in Arizona. I'm Keith Stewart. I'm also at that institution, and we have Professor Gareth Morgan from the University of Arkansas Medical Center. And this morning we had two very interesting sessions that we want to talk about. The first really related to the class of drugs we know as immune modulators, thalidomide, lenalidomide, and pomalidomide. And we heard some fascinating science and some clinically relevant information generated from the laboratory. So what did you think of what you heard this morning, Dr. Morgan?
So I'm like kind of blown away really by how useful structural biology can be. It's one of those kind of really informative situations where you clone the binding site and crystallize the binding site of these commonly used drugs, thalidomide, pomalidomide, lenalidomide, then learn the exact mechanism of action of how they're mediating their effect. And then by understanding that, we should be able to design new classes of drug which modulate the whole system in a subtly different way and bring about new modes of action, which I think is very informative to everybody.
And just for the audience who may not be familiar with this, Dr. Bergsagel, can you just briefly summarize in lay terms what this is all about?
Well, sure. I can talk about the first presentation in particular, which was Dr. Ott. And what's been evident in the last few years is that this class of drugs binds to cereblon, and that leads to the degradation of a transcriptional repressor, Icarus. And so he was then asking the question, what does that do to the cell? And he looked to see where Icarus binds in the promoters and enhancers of the genome, and he found that it's primarily actually binding in the enhancers, and that when this transcriptional repressor is degraded, a number of genes have their transcription increased, and just a few seem to go down. And it really, I think, gives us a lot more information about how this pathway is working.
So that's kind of sciencey, but this is these drugs are binding this protein cereblon, and it seems that they bind it more potently, so that it perhaps explains. But there were some other interesting features of how they bind that sort of would seem to predict whether you'll respond to the drug or not. So the question came up: can we measure this protein to see if people will respond ahead of time, or are we not ready for that yet, do you think?
The further down the line we can get of useful biomarkers that predict response, the better from where I'm sitting. But whether really measuring the level of cereblon is prognostic, how you measure the level of it, indeed, whether you look at the protein, the RNA level, all becomes rather more difficult. So for now, for basic clinical use, I think it's a suck it and see. We know a lot of people respond to these drugs. So in the first instance, I think you would go with the drug. I mean, you bring up another good point, which is if there are mutations present, should we be measuring mutations at relapse and then trying to understand if a patient's more or less likely to respond? And that's really still quite an open question, I think.
And we heard yesterday that when you look in relapse patients, up to a quarter of them might have mutations in this pathway, although it's very rarely mutated in newly diagnosed patients. What do you think the clinical implications of this are in terms of working your way through those drugs, or perhaps for future drugs that are being developed?
Well, I think that there's a lot. And actually, it was interesting that the talk from Madhav Dodapkar looking at the immune response. These drugs are called IMiDs because they're immune modulators. And he showed in the group of patients he studied that the response was correlated with an immune response. So I think we're going to need to look at how these drugs are developed, not only with direct targeting of cereblon, but also within the context of what that does to the host.
And we heard that there's attempts to develop new drugs which may capitalize on all this information, that there are already some made by the company Celgene that might go into the clinic fairly soon that target this.
I thought Suzanne Lench's talk was an interesting development of where she's been before as well, because...
Well, for those of us watching that have no idea who...
So no, it was a great talk about, so the question is, why do these drugs cause myelosuppression? So why does your white cell count go down when you're on an IMiD drug? And so she'd measured Icarus levels and related the levels of Icarus to POO1 and GATA1 within the kind of myeloid precursors in the bone marrow population. And so I think she had a cogent explanation for why people may become myelosuppressed after 3 weeks of therapy. So, I mean, that was very interesting.
All right, so this is a lot of science around how these drugs work, explaining toxicities, explaining how they work, and how we might make better, more potent molecules in the future. The second session I wanted to just touch on, we heard a little bit about some new drugs, particularly from your group at University of Arkansas that Dr. Bergsagel had originally got going, which was to look at targeting a kinase called Mech. So do you want to tell us about that?
So the story stretches back to kind of just the discovery that about 50% of patients have mutations in the RAS pathway. And so the question is, if that's so central to the mutational spectrum, is deregulation of that pathway ubiquitous in myeloma patients? So if it is, if you have a molecule that targets the bottom of the pathway, do you see responses? And so we've treated quite a few patients with a Mech inhibitor, which blocks the bottom of the pathway. And the interesting and provocative thing is that several patients with single agent exposure obtained very rapid and complete responses. And so the task we have now is to really try and explore the use of this trametinib drug fully in a more controlled fashion.
And it sounds like you've already started to do this in some combination therapies too.
Yeah, we have a phase 2 study, and then once you can see that you're seeing responses in that controlled fashion, it's very easy or potentially feasible to add additional agents which block other parts of the pathway that prevent paradoxical signaling when you inhibit one side of the pathway. Right. So it should be good, and I think there's a place for this pathway.
We also heard about PIM kinase inhibitors that have some activity too, specifically one from Novartis, and I think there are some other in development. What did you think of that, Leif?
Well, I think the PIM kinases are an attractive target. It's a kinase that doesn't require a mutation to be constitutively active. Just by being expressed, it's active. And there was a very nice response rate to that. So I think going forward, we can expect a lot.
Yeah, I guess we didn't talk at this meeting about AKT inhibitors, which have also shown some promise in CDK5. We heard about those at previous meetings. So it does seem like there's a number of kinase inhibitors in development that might ultimately be added in combinations. The last drug I just wanted, or class of drugs I wanted to get some feedback on are the so-called bromodomain inhibitors, which have got people excited, at least in the lab. But tell us a little bit about what you heard about those and where they're going in the clinic. And you have some experience with that as well.
So we heard from Suzanne Trudel about the clinical trial of one of those drugs from OncoEthics, which has shown very nice activity in leukemia and lymphoma, but she was saying the trial was stopped early before they could evaluate it fully in multiple myeloma. And preclinically, we heard from Konstantin Mitsiadis about more information about how they work and possible mechanisms of resistance, which might inform their further development.
So I thought Konstantin made a very good point about the complexity of understanding what these signaling pathways do, dependent upon the genetic background of the cell. Because you may have one compound that's kind of leads to a response in one genetic background, but in another genetic background it might breed resistance. And so there's a way to go for us to fully understand the kind of activity state of the cellular signaling and what that means for choosing a targeted therapy.
The summary, I think, from this meeting in general has been, as in previous years, just a plethora of new agents coming forward with activity, providing hope for patients. We heard about kinase inhibitors. We understand how the drugs we use are working, or better, how the drugs that we use work. We heard a lot about immuno-oncology that you'll see in some other videos. Putting these things together, I think, is really going to provide hope for our patients. So thank you for joining us.